buprenorphine prescribing practices get a change. It was a couple of members' ideas on the panel to say, hey, maybe we should kind of have just a Q&A session. So today we're just going to be going over what are those changes at the federal level, what are they at the state. Thankfully, Mark did a fantastic job really kicking this off about a month ago with his presentation. And then we have some questions at the end that we got from folks over the last month. So we'll go over those questions and then also some other, what other questions come up from the group. Mark or Tony, any additional thoughts from you too?
Sure. Well, hello, everyone. I see many names that are familiar and the opposite as well. So hopefully we're pulling in lots of folks here for this dynamic topic. As Katie had mentioned, trying to go a little bit different this time. My family was asking, oh, what do you got lined up for tomorrow, yesterday? Because that would have been last minute. This was planned for more days than last minute, right? And I said, oh, we're doing a Echo buprenorphine CE. And I was like, Echo. I'm like, that's that one I'm always ranting about where it's like actually dynamic and gets people engaged and in the usual platform has the actual patient cases, not the textbooks from 1978, just from 78 seconds ago. So really happy to get everybody together today in a little bit of a different format of just panel wise, if you want to call it that, but meeting of the minds, having everybody on board where we've got clinical expertise here, we've got insurance coverage, managed care expertise here, statewide information as well too, because this is federal information, but there's a lot of state to state differences as well. Nothing new there, of course. With that, I think Katie, I think you called out Tony, so we'll say Tony's next.
Yeah, not really much to add to what Katie and Mark said. There have been obviously changes. There were a lot of questions about what this means and how it's going to be implemented. The changes from the federal omnibus bill that removed the requirement for the X-Waiver, which is fantastic, but it leaves us kind of in a vacuum of how was this actually going to be done in West Virginia. And when we were talking about this, I said, I don't know that I should be on the panel because I probably have more questions than answers. But one of our goals is for any questions that cannot be answered today, we'll record them and dig deep and find the answers and bring them back to anybody that might have inquiries that we can't help you with.
Could I also ask Angie to introduce herself? I'm super grateful to have her joining us, and I don't want to mess up that last name, so I'll ask her to introduce herself. Grateful to have her here.
No worries. My name's Angie Wojcik. I'm Director of Rational Drug Therapy Program, and we do the prior authorizations for the West Virginia Medicaid Program and PEIA.
Anybody else sort of a part of our ECHO team that would like to say anything before we go through these? Going once. Twice. Okay. Peter, I think you have the power of the slides. Okay, so Mark, since I sort of stole this from your last presentation, I don't know if you want to go over any of these.
Sure. All right, so if you're here, it means you haven't been living under a rock. The X-Waiver's gone, all right? I feel like I should have something to pour out, but there's carpet in the room, so we're not going to do that. Anyways, the X-Waiver's gone. By that, of course, we mean what came from Data 2000, been a couple decades now, that said that to prescribe buprenorphine for opioid use disorder as medication for addiction treatment or medication assisted treatment. There's enough acronyms for everybody, of course. That you had to have not just the DA license, but you had to have this extra thing that we chose to call an X-Waiver. Hindsight is always interesting. That is gone now. So the MAT or MAT Act recently here now has said that the X-Waiver is gone. Buprenorphine, it will be treated as the controlled substance that it is, just like all other controlled substances. One of the biggest perceptions as far as barriers for providers to get an X-Waiver was that they required the extra hoop of going through additional training, which was typically an 8-hour CE style, perhaps hands-on as well, extra training for an add-on to the DEA license. Technically, that's gone. The second act, though, is the MATE Act, M-A-T-E. So we got rid of the X and we added an E. Go with me. Made that up on the fly. That is basically saying now that everyone with a DEA registration license is going to be required upon renewal or first initial acquisition to do an 8-hour substance use disorder SUD training, which will be starting this summer, be here before we know it. If you think about that, that's, every headline I've read, perhaps yourself as well, it's kind of skipped over that. It's like, oh, they got rid of the training. No, they didn't. The training's still there. And now it's for everybody. That's an interesting power move, culture shift, if you think about it. Because before it became a barrier, it was conducted by those who wanted to do this. Now it has to be completed by everyone. One of the things we'll go over, I believe, will be, well, what's it going to look like? Well, it's barely March, so it's not June 2023 yet. And it'll be interesting to see who's involved with the creation of those. So, fingers crossed along the way. All right, so without the X-Waiver, folks don't need that extra DEA registration effort to be able to prescribe buprenorphine for opioid use disorder. Please keep in mind in the background, there are microgram products that are out there. It's a controlled substance class 3. That's in the pain management realm. A little bit different than this topic here today, but those things are out there. That's always been a CS3. Well, the newer products anyway. But now there are also no limits on the number of patients a prescriber can see and prescribe buprenorphine MAT. Previously, it was not necessarily an algorithm, but you started out with 30 patients. After a little bit of time and a lot of effort, somebody could then increase to 100 patients. And then was it 270 or 275? It's not going to be a multiple choice question, folks, because it's history. There's no more of those limits. The limits are gone. Now, in the past, why would there be limits? Well, it is a controlled substance, so perhaps the thinking was let's not have. It's so interesting to say in 2023, but let's not have everyone prescribing and dispensing this stuff everywhere. Think about that in the eyes of hydrocodone or oxy or any of the other things. But anyways, that's gone as well. So X-Waiver's gone, but all registrants for a DEA registration will be required starting this summer to do the 8 hours of training. In the background, though, we always want to remember that there's the federal corresponding legal responsibility, Controlled Substance Act. I don't remember the paragraphs and those little squiggly S things. That says that it's the prescriber and dispenser, or plural, that are required to minimally be reviewing and confirming appropriate diagnosis and scope of practice. Now, I am not a gambling man. I go to Vegas for conferences, nothing more, nothing less. I would venture to say that just about everyone, if not all here today, would go well beyond ensuring diagnosis and scope of practice. It would actually be hard to not do that unless you're talking about eventually deemed criminal cases at different levels. So it's really providing that extra care. So that's 2 or 3 bigger bullet points along the way. We got more info coming, but did anyone even, especially within the panel, but even questions, thoughts, anyone want to add anything there? All right. Onward we go. Did anyone else want to take the state level one or keep this podcast host voice going? Or okay. So we've got some other folks on here that know this stuff a lot more, but we'll go with this voice, I guess. But one of the natural questions, and today is in the background kind of devious. We're looking to get more questions that are unanswered from everybody. That's one of the goals here today, if you think about it. It's not a typical learning objective. Hey, we didn't have learning objectives. Anyways, these were some of the questions that came up in the last couple weeks, and I'm sure it's not unique to our state. But how is it roll in West Virginia compared to, say, Ohio, California, Puerto Rico, wherever? So within our state, and we have some expert reps here today too, West Virginia Medicaid no longer requires the secondary approval registration, colloquially known as Gainwell. I believe that's locally anyway. So if you stop and think about that for a second, like not in the past, again, this is the past. We had not only the X-Waiver, the extra training and all that, but then we had these other things that had to be done too. And here we're talking about just typically the prescribing side. Patient hasn't even walked into a pharmacy yet. So, but once that does happen, pharmacy in general has removed the edit requiring that additional enrollment as of, good golly, over a month ago now. So that's a big update. Basically, if there's any concerns, issues like that, you'll want to be reaching out appropriately here. We've got some information on the slide here for you. Don't know if Angie or Tony or anybody wanted to add anything there.
What I wanted to add is, I know for us, that's going to make a significant difference. That has often been, I mean, it's for some of our providers been months and months before they're able to independently prescribe. So I know for some of the changes, that's going to make a big impact for us.
I 100% agree. The whole extra Medicaid thing has been such a burden for so many people. So I'm so excited about this part.
Dr. Lander just asked a great question. We will make sure to get that sent out to everyone. Maybe we can do that when the notes for this meeting get sent out.
Good question.
Mm-hmm.
And did anybody have any other questions in this regard too? Because this is, one of those first next steps, beyond the federal information along the way.
Yeah, I had a question, but I wasn't too sure if you were going to address it later. In West Virginia Medicaid, there's all those therapy requirements. Are they still in place for our state?
My answer is I believe so. And we weren't sure, I think some of that got suspended with some of the COVID measures, and we are not sure if any of that's going to change when any of those measures expire. But to our knowledge, there haven't been any big changes related to that. I know we've communicated in terms of their expectation for individual therapy. We've communicated just about staffing shortages that are across the state to them. A great question.
And for people who have already completed the training, are we to do the additional 8-hour training come June?
It'll be whenever your individual VA registration renews, which is usually to my knowledge, it's every 3 years. I believe that could be different years for different folks.
Adina, I was on a call with ASAM, and so the DEA hasn't actually picked what trainings are going to count yet, but the hope is that anyone that's done an X-Waiver training, that'll be sufficient for all of them. Now, I don't know if you have to do a new training every renewal cycle, so just like a one-time training. So I think we're all going to be exempt and we won't have to take any trainings if we've already had an X-Waiver. So if that helps.
Yeah, that's my understanding too. And if you looked at the text of the MATE Act that was introduced, then rolled into the omnibus, and the omnibus is like 900 pages, and I truly didn't have the energy or the attention span to actually read it. But the MATE Act, which was much shorter, exempts some people. For physicians, if you're board certified in addiction psychiatry or addiction medicine, you wouldn't have to take this. For non-physicians, you have to have the 8-hour course. And I think, like Jeremy was saying, I believe the intention is, well, shoot, even if you come to these ECHO programs, if the as far as the bill was concerned, if you have 8 hours of ACCME, which I believe these ECHOs are continuing ed that are approved by ACCME. You do 8 of those in those 3 years, you would meet the requirement. But specifically, supposedly, the Attorney General is supposed to send us all his qualified prescribers by March 22nd, an electronic notification of specific educational requirements. Just like in January 12th, those with the X-Waiver got the DEA, the new thing that took the X-Waiver off our new registration. So March 22nd, by March 22nd, we should receive some specific information about the education, but there should be some people exempt on this who participate in this and who've been prescribing Suboxone for a while. Can I just ask a question? Angie, are you hearing the specific, like, is this what we got from Dr. Harvey consistent with what you have heard? Because, you know, implementation, the trickle down to actual implementation can take a little while. And I was wondering if you're hearing consistent things that we heard from her.
Yep, that's consistent. So the changes to the system have been made, and the changes to the criteria have been made. Now, I don't think that they've been posted necessarily, and I know for PEA, the new changes that the XDEA is not required wasn't posted, but we are following that it doesn't need to be done. We're not asking that in the criteria set anymore. And in the systems, there's nothing causing it to reject because there's no XDEA numbers. So everything is updated.
Great, that's fantastic news.
Interestingly enough, if folks, I'll toot the horn of RDTP folks. The way that our state organizes Medicaid and that relationship is not necessarily unique, but as various other studies have shown for cost savings over the years and decades, it enables things like this to hit the ground running really fast. So if we hear from colleagues in other states, that's one of those where down home and country roads ends up being a little bit better. So that's huge. So
Absolutely.
Good luck in Manhattan is what we're saying, right? Alrighty. Did we want to go to the? There we go. All right. I guess the theme is. I'll go through here. So status quo is our theme here, but just remind again, building right off of actually what I was just saying there of healthcare, but particularly pharmacy is rather unique when you look at laws in our country. Typically, I do not have a JD, so disclaimer here. I don't even have whatever the lower levels versions are. I got a speeding ticket the first week I moved to Morgantown. But anyway, in healthcare, particularly regarding pharmacy, the more stringent law, regardless of who makes it, the more stringent law is what applies. I'm told by legal experts that that's semi-unique because usually federal law trumps anything. But in our realm, it's always whatever the state says here. Now, we just covered some of the state things and all the barriers are actually already removed. And that might take a little bit longer in some other states. Probably happening by now, but just in general, keeping that in mind in case there's any further changes. I know within the last week, we saw another DEA announcement. Maybe we'll hit that up at the end of these slides, but telehealth concerns. One of the looming things, particularly in being a pharmacist, I am propelled to bring up is, the concerns of what about the supply? For years, any of the circular debates on buprenorphine MAT have been all on the prescribing side, but then what about a patient going to a pharmacy being told we don't have it, we can't get it? We're already at our quota per se. That's a reality that's out there. I don't think I'm overstepping to say that we hear from the top that that's being removed, but down at the bottom, there's still discussions of, got my eye on you. And that's a concern, and it'll take some time, but we're certainly getting there. So in a healthcare professional sense, one of the wonderful things here is that we're all interprofessional. Just remembering that there may need to be realistically conversation still about some people's processes within clinics or the prescribing side, and vice versa to the pharmacy side, of having really good conversations, getting everybody to the phone. It's tough because a lot of places don't even answer phones anymore, and email's not always enabled. But having the conversations about what your practice is doing, so that can be conveyed eventually from a pharmacy to a wholesale distributor, because they have to check on that stuff now. I try to be careful sometimes how to word things, but sometimes you just gotta say how it is. There's been a lot of opioid settlements out there, right? And at the core of that, when it was distributors, one of the core things was a lack of double checks, thresholds, limits, things like that. And now they're doing that with buprenorphine, perhaps others as well, controlled substances, and the boy and the wolf and the everything. And it's like, well, that's what was asked for, and now it's here. It has been here. So we have to carefully navigate those tricky country roads, but it's not barriers, it's just more conversations. It's documentation on a lot along the way. Has anyone experienced any of that even recently? It should be hopefully subsiding, but any thoughts?
I have a question.
Sure.
Will prescribing open up to other disorders like PTSD and major depression and chronic pain? Will people be able to freely prescribe for that with Suboxone?
I would venture to say that would be anyone's answer would be still on the opinion side, because we're probably not there yet. So, and the idea of off-label, dare we say that other medications have off-label utilizations? For crying out loud, for decades everywhere, right? Yet when we have a CE, we still have to sign off on saying, "Oh, we're not going to talk about that." So there, I told you we're not going to talk about it. But Bruno's in the room, right? Got a kindergartner. What do you want? You got to talk about Bruno, and it's at some point when you have a controlled substance prescription opioid that has magnificently different pharmacokinetics, dynamics, and pharmacology overall compared to other prescription opioids, to not talk about it is the actual problem. It doesn't mean everyone everywhere, but proceeding with the respect for the pharmacology is a big thing there. So much shorter version. It seems observationally we're not there yet, but it will be.
And Dr. Bell had asked if residents are allowed to write for buprenorphine under the group DEA, or would an attending have to do so?
Anyone have initial thoughts there? Or
Yeah, Dr. Husted or Dr. Herschel, I'm wondering if either of you as attendings have thoughts on that.
I think as long as you have your own DEA, you can do it. I'm not sure about trainee DEAs, like when you're first starting out in residency. I don't know if there's a lot, but if you have a DEA, any kind of DEA without waiver, I think anybody can write them, including people that were waiting for what the Medicaid waiver thing, Melina thing that I did when I did mine 5 years ago, I waited like 6 months to get mine. So, but I think anybody with the DEA, so basically most third years who had their own DEA can do it. I don't know about the institutional DEAs.
I did have a fellow who tried to prescribe Suboxone under his own DEA without the X-Waiver, all that, and the Medicaid follow-up that goes on with that. He was unable to prescribe Suboxone with his just regular DEA. No, that was a couple weeks ago.
I wonder if he didn't do it correctly though, because he had never done it. Because you still, for the it shouldn't block it if he has an DEA. So, but I'd like to have more of them try it. I've told them like to do it and then to call the pharmacy and pushing it through. Yeah.
Yeah, as long as the DEA is registered with Medicaid, that's another factor that might be causing the issue.
What does that mean exactly compared to what we used to do? So registered with Medicaid.
It's the same as, yeah, it's the same as before, but all providers have to be enrolled with West Virginia Medicaid. Not with an XDEA number anymore, but they have to be registered with Medicaid and have their DEA on file and updated.
And wasn't there something recent, like when I just think within the last 2 or 3 years, Angie, where even people that aren't credentialed to be reimbursed for Medicaid have to register as a prescribing provider or whatever?
Yeah, that was a CMS rule that had to go into effect. So they did start that. It's the enrolled prescriber edit that will fire. They just have to be enrolled with Medicaid. So there's 2 steps. They have to be enrolled with Medicaid, and then they have to have their DEA current with Medicaid.
This is exactly why we wanted to do this panel presentation. Because I was too chicken to answer that question. I haven't caught it by now. I'm fully fluent on being transparent. You know, when you look at the healthcare law side of it, it says DEA registration. That's the qualification. But then there's all this other stuff like we wanted to bring up today, the other questions that come up of, you know, getting lost in the weeds. No, this is not a cannabis talk. It's there's just a lot of other stuff, a lot of conversation that still need to happen. You know, in the regards of the residents or any other institutional thing, we want to make sure everybody, the checks and balances are there. Conversations have happened. Because you know, I'm in a different profession. If an attending doesn't know that things are going on, take buprenorphine out of it, any medicine, it would be a relationship concern professionally. So it's, you know, just having those conversations.
Dr. Bowe brought up a good comment in the chat box. She said, what's worrisome is many providers seem to want to write for buprenorphine for methamphetamine use disorder because their patients tell them it reduces cravings for meth. Dr. Bowe, do you see that a lot in Charleston, or other providers on the call? Are you seeing that?
Yeah, definitely in Charleston.
Yeah.
Shoot, I had one who wanted to write for it for someone with benzodiazepine use disorder.
Oh boy.
And Adina, isolated benzo or isolated stimulant use disorder, not with comorbid opiate use disorder, or
that's right. Patient not meeting criteria for OUD at all, doesn't use it at all.
I think the thing I would say from my experience is that a lot of the methamphetamine, at least in North Central West Virginia, has fentanyl in it. So I could see where that might be reasonable, but yeah.
There's not even DTC, direct to consumer advertising for that. It's amazing how information gets out there.
Laura asked a question in the chat as well, and feel free to chime in as well, Laura. I'm sure you'll relay the question much better than I will, but she was asking, what impact will this have on the program modality of treatment? If patients are able to gain access without participating in a comprehensive treatment program, I imagine they will choose the easiest route.
So I would just throw in that despite the changes in waiver requirements or that being repealed, and the ease of not having a secondary X-Waiver to register with Medicaid payers, the state law 16-5Y, which is licensure and certification of OB-MET programs and or attestation if you're seeing less than 30, is still in effect. So, you know, all the programmatic requirements at the state level by regulation, which does require for ongoing continuity care, all those, you know, therapy and, you know, this comprehensive kind of approach is still required. Now, you know, there is the attestation route where if you have less than 30 patients, you just like, you don't have to get licensed with all your policies and procedures. You're still supposed to follow the requirements of trying to prevent diversion, doing drug testing, linking with mental health and individual therapy or group therapy, but you're not held to an audit standard. You're just saying that you will do that. So all those requirements are still in place. So
Does this law change the amount of buprenorphine you can prescribe at any time? Like now, can you write like 90-day supply with 3 refills?
Mark, you know that, I mean, I obviously I know that it doesn't matter now how many patients you treat. So most of us had 275 or 100, and now we can take care of 1,000 patients. But Mark, do you know the answer? Is it just the traditional like Schedule 3 DEA as far as refills?
Yeah, I'd love to say, hey, there's none, but it's a controlled substance class 3. So you go like anything else, 3s, 4s, and 5s, generally the same bucket. Couple nuances here or there. Pharmacy law people would rip me on that one, but the point is not C2. That's a bigger thing, I believe. So. That last question from Laura, that's the can of everything, I believe, question. So I really appreciate that. Thank you, Laura. It's opening up that conversation of, and it's typically circular. So we're only gonna go so far with it today because I'm not fast. I'm not a runner. So I walk briskly in a straight line and get somewhere instead of running in a circle. I know that all of you have been in the circular conversations of, well, if you increase access, then what about getting the actual, all the psych stuff, the group stuff, the everything else, in addition to the medication, and vice versa? Well, what if it was just medication? There's hundreds of thousands of people in need of it, not enough people to get it. There's no perfect answer. That's the world we live in. And it, you know, if everybody's helping somebody, that's where we'll get. Every situation is going to have its bad apples. There's an equal circular conversation on should there be no enforcement whatsoever. I'd put my professional judgment out there, which I never do on a mic, and say that would not end well. I've seen scenarios with my own eyes where it was criminal, it was not clinical. And then folks would say, well, yeah, but it's buprenorphine, so isn't that better than getting, you know, diacetylmorphine or oxy, whatever out there? Relatively, but are we helping people? You know, one of the ideas or answers per se to that last thing was, you know, folks were getting their own treatment on the streets too. But is that really treatment? I mean, I literally just said it and I meant not to. That's just the medicine to, you know, the whole calculus of getting by instead of getting high and all that stuff. But I've had the charts before in previous echoes, but there's a lot to unpackage in those conversations, requires at least 4 hours and is not even part of the 8 hours required. So we gotta start somewhere.
I can offer a little of a suggestion on the slide that's currently up on the wholesale distributors. So like Mark alluded to, we don't really know how much this is going to up prescribing, but it's assumed that it will up it a little bit. And there might be supply issues that trickle down from that. And again, that's hard to predict. If you find that your patient is having trouble finding what you've prescribed, whether it's Suboxone films or tablets or Subutex or whatever it might be, and they've checked all the pharmacies within the area to a reasonable extent, a lot of insurances will offer some sort of an emergency supply coverage. I can, of course, only speak to Medicaid and PEI with certainty, but Medicaid, for example, if the pharmacy puts a 99 in a certain field and submits it, they don't even have to call us for an emergency 3-day supply of anything that requires prior auth. So that's helpful knowledge too. With PEI, I think they require a call to somebody, but do offer that because the insurer will most likely not want the patient to be at risk for relapse. So it's something that you can have the pharmacy check into.
Thank you for that, Angie. Sharing the codes, man.
The pharmacies all know them.
You know, a patient perspective, you don't know if you're talking to a airline attendant typing away or a pharmacy just typing away.
Yep.
Lots of codes in the background. Tom Minigan is bringing up here, you know, really appreciating the wholesaler portion of this. There was, I even personally attended various things in national conferences where it was, well, is it the DEA or the wholesale distributors? You know, who's got these limits, thresholds, whatever terminology we go with. And most recently it was determined, well, okay, it's at the wholesaler side, hence my wording earlier. And Tom saying, well, nebulous ratios, to say the least. It doesn't end at buprenorphine. I was recently talking with a pharmacist. I could even say it was related to them because that doesn't even narrow it down. We got a lot in our family. Who was just called by a wholesale distributor because they dispensed like two prescriptions, not even bottles, of tramadol. And like, whoa, I hope that catches all of your ears. Like, well, yeah, it's like the most widely utilized prescription opiate across the planet, except in America. Yet, if you're getting calls on that, imagine how tough it is with buprenorphine. But this is what we're seeing. This is post-settlement era, and it's tough. So, Tom brought up I'll just read it here. Buprenorphine to Suboxone and control to non-control ratios are monitored closely. So you bring up a wonderful point there, Tom, that I'm going to add on to. So buprenorphine alone compared to buprenorphine with naloxone, you know, the general intent was to prevent the IV abuse. And if you look at the pharmacology and the package insert, that would not be the case. Yet the street value of solo ingredient buprenorphine continues to be more. Whereas in the healthcare supply chain, it's incredibly more cost efficient, as in cheaper, for solo ingredient buprenorphine. So to summarize, the street and the healthcare supply chain, illicit and legal, are completely polar opposite. And it's probably the first time in the history of mankind that the healthcare supply chain could actually educate the streets. It's usually time for us to learn from the other supply chain in other substances. So that's an interesting one. I personally have had that conversation with people all the way up to DOJ, DEA level. No, not the AG, not that cool. And it's usually yeah, but that's what the street says. Ending. It's very interesting and concerning. So hopefully that will be evolving in a positive way in the future here. But yes, the reality of the quotas, limits, thresholds, another possible barrier at pharmacies is a reality out there. And for some reason, it's never, ever in the headlines. So you got somebody on LinkedIn yapping about it as a comment. Guilty. Of like, hey, we need more than MAT and MATE. We need this other stuff addressed as well too. So, and I saw some comments in here. There was we even got one with a thumbs up. I think Marianne was the one of saying, yeah, experiencing this with pharmacies. They're she was saying Clarksburg area. It's beyond there as well too. So, so that's that. It's a tough landscape. So, any other thoughts, questions, opinions, personal facts, whatever in that room?
I don't know the full history of this and I haven't dug into it, but just in articles that I've read about this recently, I guess in the mid-90s, France had a similar like special license or whatever to prescribe buprenorphine. And in 1995, France got away from that. So kind of doing what we're doing now. And supposedly after 4 years, the overdose rate decreased by 79%, which is huge. And with a lot of the care being trickled down into primary care settings. So while West Virginia still has I believe, the most prescriptive office-based MAT laws in the country. And this legislative session has certainly not lightened them at all. I mean, the session isn't over. There's, March 11th is the end date, but they're really pounding hard on, limiting residential beds. And there was going to be a limit. There was a bill to make office-based MAT even more restrictive, but that particular bill died right now. Who knows what's going to happen in the next 15 days, but I don't think we'll be like France, because we still, at least in this state, have the state regulations and the state rules under OFLAC that has a fairly heavy hand on what can be done in the state. Not to say that there aren't primary care providers providing MAT treatment, but they still have to ascribe to all the very prescriptive state laws. But hopefully this will be the start with data of influencing to get treatment when people want access, and being able to deliver it at that time, and not having just kind of like the project that Chestnut Ridge and the ED are doing. When people come to the ED and they want treatment, being able to deliver that treatment and putting them quickly into care. So this is a first step, but not the last step for sure.
I was just going to say, I know we have looming questions
Yeah.
too. So
Yeah, these are the questions that folks sent us. And actually, I think, Tony, you've already sort of touched base a little bit on the first question. I'll also be honest, I don't remember who sent us these questions. Thank you in advance for sending these. But one of the questions is, will OFLAC continue to enforce caps on each prescriber's number of patients through their ODMAT licensure program? Is attestation for 30 patients or less still required? And are there plans to adapt or change these rules by the agency considering federal changes? And Tony, you've already touched on this a little bit.
Yeah, not the cap. I don't think the max of 275, but all the rest. Yeah, it's so far still licensure and still attestation for less than 30.
And Dr. Bowe sort of asked an example of the second question. Are there other state level statute or rules that are impacted or anticipated to change with the federal changes? Team, is it fair to say we're sort of not sure yet? Sort of depends on maybe the end of this legislative session.
Other than PEIA and Medicaid getting rid of the secondary Gainwell thing, which is so awesome. But that has changed. But other than that, yeah, I think we still have to wait.
Mm-hmm. And then what will the DEA renewal CE requirement look like? I think both Mark and Dr. Houston touched on this, which is that we don't exactly know what that's going to look like. There was another question that we got on the second page. So what impact do experts expect the changes will have on access to the related medications? Will pharmacies more likely to stock them? Will wholesalers see them as less suspicious? And I think we've sort of already generally talked about these as well, is that it's a little bit maybe too soon to tell. Anybody on the panel have thoughts on that?
I think Angie touched on this very succinctly yet eloquently earlier. It's probably not a smart goal to think that there's going to be a huge change in reality. Maybe I'm simplifying it too much, but the idea that an 8-hour CE was preventing a prescriber from getting this done is probably not the most intelligent statement. And I hope that most could agree with that, contemplate that. There's a lot more going on. Just pretty much summarize the stigma. I think we lose a lot of stigma in the shuffle sometimes, but there's still the wholesaler side. That's another can of worms. But the prescribing side, that idea of not having a limited number of patients for those who are prescribing, it might be more impactful than eliminating the X-Waiver in itself. because again, it came from data 2000. It's 2023. I mean, if you haven't yet, you know. But it's forward progress. It's a first down. First down's not necessarily a touchdown. We're not doing a halftime show here. It's forward progress.
Mark, I have a question that's not on the sheet of these slides, but you
Allowed.
made reference to it about the DEA, like what is the new DEA telehealth thing? Share.
So this was Friday at, I'm gonna guess 4:55 Eastern. Announcements are always at 5 o'clock on Friday from those that utilize our tax income. There was a proposed permanent, so proposed is the important word. It's not, we're not having a CEO on it just yet. It's proposed by the DEA to continue the flexibility with telehealth, particularly in the realm of this buprenorphine conversation. There's 2 documents. They're rather long. I had more of a family weekend, so I haven't been able to read the whole darn thing yet. But a very trusted colleague said, make sure you read the whole thing because there's very important details in there. But the overall idea that all the headlines are covering now is that people will be able to do telehealth and not have a concern for that initial in-person evaluation. I am told, as in the last 8 hours, that it's delayed to say that it's got to be at least a month later. I have not personally read that yet. But the overall idea is to say, hey, during COVID pandemic times, we have laxed to allow more telehealth. Now, 2 sides of the coin there. Will that open up a lot, or if possible, too much of a controlled substance? Or will it make it increasing access, or both, or some of one and some of the other? That's what's on the table here now. Nothing's etched in stone to my knowledge, but it's the big proposal by the DEA last Friday, so less than a business day ago. Thoughts, questions, anything with that? I can probably, seems like everybody's in the chat. I'll share a website. And again, folks, it's like I tell our student pharmacists, our medical fellows, and everybody, we've got one of them on here today. I know that for sure, Victor. So check the references as in read it yourself. Never trust the slide. I don't care if it's mine. But to read through the things ourselves. So I shared that in the chat.
I'll stop the screen share here and just say thank you all so much for presenting on this. And we still do have, 8 minutes. So a lot more discussion to be had. So anyone with comments, questions, just feel free to chime in.
One thing I will add in that the link that I just sent for the DEA telehealth concern, if you scroll down to almost the bottom where it's one of the bullet points is a link you can click on telemedicine rules summary. If you don't have time to read 150 pages out of 2 documents, that's the one you want to look at. And that's where it says initially okay for 30 days, but you're going to need an in-person assessment eventually as far as what's proposed to be continued. So.
And I'll be sure to attach that link into the recap email as well, so everyone will get it after this session.
Also, I'm going to be like needy here. What did folks think about this platform? Certainly not our traditional Echo, which is great in itself, but like just conversational. Feel free to chat, video, whatever you got going on.
Feels more relaxed. Got a thumbs up from Derek. See you in your plan.
It worked.
Awesome. Thank you, Jen. Nikki chatted in saying, great, nice to mix it up every now and then. Thank you for the feedback. We do have a poll we could launch as well. It always just helps us as an ECHO team to improve and make sure these the sessions are catered to you all and what you all need. So we can do that as well. Thank you, Laura, for chatting that in. No worries at all. And we are recording today's session, so if you happen to miss it or you want to pass it along to a colleague or anything, that will also be in the recap email. Any final comments, questions from the group?
Next conversation, OTC naloxone.
That sounds good to me. We'll make sure to schedule that topic. Alrighty, well, thank you so much to the hub members, the panelists. You all are awesome and put this together so last minute. And sending my gratitude to you all, and also sending my appreciation to everyone on this session today. It wouldn't be possible without you, so thank you for joining us today. I'll pop up a really quick poll here and then say the announcements. Once you finish the poll, you're welcome to log off. Let's see here. All right, is everyone able to see a poll now? Getting head nods, thumbs up. Thank you all so much. I love how you guys are awesome for giving me like nods and stuff like that. Thank you. The only announcement I have is the next session will be on March 27th, and Sarah Lee Fight will be presenting on marijuana retention and Suboxone. We are going to be canceling the March 13th session. The ECHO team will be out of office for a conference. So I'll also be putting that information in the recap email. Thank you all so much. It was great to see you all.